Tonight we are going to discuss postoperative nursing management. The postoperative phase begins when the patient leaves the operating room and extends until the last follow-up visit with the surgeon. The patient will initially go from the operating room to the post-anesthesia care unit or PACU. Some hospitals and ambulatory surgical units divide the PACU into two phases. Phase 1 PACU is used during the immediate recovery phase where intensive nursing care is provided. The patient then transitions to an inpatient unit or to Phase 2. Phase 2 PACU, the patient is prepared for an inpatient unit. They may be waiting for a bed, an extended care setting, or discharge. You usually see recliners rather than stretchers or beds in this phase. In the postoperative phase, nursing care focuses on reestablishing the patient's equilibrium, alleviating pain, preventing complications, and educating the patient about self-care. The goal is for the patient to return to an optimum level of function as quickly as possible while maintaining patient safety and comfort. Handoff report is given by the anesthesia provider and OR nurse to the PACU nurse. Handoff from the anesthesia provider to the RN and RN to RN handoff need to include the following: the patient's name, gender, and age, allergies, any surgical procedures, position during the surgery, length of time in the operating room, and anesthetic agents and reversal agents if any were used. In addition, handoff needs to include estimated blood loss or EBL and fluid loss, the last set of vital signs and any issues during the procedure. An example would be nausea and vomiting. Any complications, comorbidities, a list of allergies and medications taken at home, immediate postoperative considerations such as pain, whether the patient's on a ventilator, and blood pressure, language barrier, and location of the patient's family. Ideally, the anesthesiologist should not leave the patient until the PACU RN is satisfied with the patient's airway and immediate condition. The primary objective in the immediate postoperative period is to maintain a patent airway and prevent hypoxemia and hypercapnia. In these top diagrams from your textbook, page 439, you can see what can happen when the patient is unconscious, lying on their back with all muscles relaxed, including the muscles of the pharynx, and you see this in general anesthesia. In A, the lower jaw and tongue fall back, obstructing the air passages. This is called a hypopharyngeal obstruction. Signs of this include choking, noisy and irregular respirations, low oxygen saturation, and within minutes you can see cyanosis, which is a blue dusky color of the skin. In B, tilting the head back to stretch the anterior neck structure lifts the base of the tongue off the posterior pharyngeal wall. The direction of the arrows indicate the pressure of the hands on the forehead and under the neck. In C, opening the mouth is necessary to correct a valve-like obstruction of the nasal passage during expiration, which occurs in about 30% of unconscious patients. Open the patient's mouth, separate the lips and teeth, and move the lower jaw forward so that the lower teeth are in front of the upper teeth. To regain backward tilt of the neck, lift with both hands at the ascending rami of the mandible. The anesthesiologist or CRNA may place an oral airway to maintain a patent airway after anesthesia. In the bottom diagram, the airway passes over the base of the tongue and permits air to pass into the pharynx in the region of the epiglottis. Patients often leave the operating room with an airway in place. The airway should remain in place until the patient recovers sufficiently to breathe normally. As the patient regains consciousness, the airway usually causes irritation and should be removed. To monitor cardiovascular stability, the PACU RN assesses the patient's level of consciousness, vital signs, cardiac rhythm, skin temperature, color, and moisture, and urine output. When trouble brews in the PACU, what do we do for overall hemodynamic instability? Let's talk about hemorrhage and shock, which occur in PACU or even several days after surgery. Types of shock include hypovolemic, cardiogenic, neurogenic, anaphylactic, and septic. In the immediate post-op period, hypovolemic shock is the most common and is associated with hemorrhage from the surgical site. Classic signs of hypovolemic shock are pallor, cool, moist skin, tachypnea, cyanosis of the lips and gums, rapid, weak, thready pulse, narrowing pulse pressure, hypotension, and concentrated decreased urine output. Primary intervention is to increase IV fluids. We use lactated ringers, 0.9% sodium chloride, and colloids. We administer ordered blood transfusions. We give medications to elevate the blood pressure, and we position the patient flat with legs elevated at a 20-degree angle with the knees straight. We look for causes. For example, we're going to check the dressing. You also may see hypertension and arrhythmias. Hypertension is common in the immediate post-op period due to stimulation of the sympathetic nervous system from pain, hypoxia, and bladder distension. Arrhythmias are associated with electrolyte imbalance, hypoxia, hypothermia, stress, and anesthetic agents. For both, the underlying cause is treated. Further assessment in the PACU includes neurostatus, and we assess the level of consciousness with every vital sign check. Gag and blink reflexes are assessed when the patient responds to commands and also with vital sign checks. Musculoskeletal status. Are the arms and legs moving? We have to expect the patient to move both their upper and lower extremities. If they don't, you need to ask why. For example, did they have spinal anesthesia? Did they have previous impairments such as a stroke, or did they have orthopedic surgery? Post-op nausea and vomiting, PONV, occurs in about 30 to 50% of patients. At the first sign of nausea, you want to turn the patient's head to the side. Risk increases for females, age less than 50, history of post-op nausea and vomiting, and opioid administration. Antiemetic meds are given intravenously and include scopolamine, dimenhydrinate, promethazine, metoclopramide, prochlorperazine, hydroxine, and ondansetron. For pain, IV opioids are used. They provide immediate pain relief and are short-acting, so the chance for respiratory depression due to an interaction with general anesthetic still in the patient's system is minimized. Skin assessment includes color and the wound dressing. Is the dressing dry and intact? Is there adequate circulation, particularly below the point of a dressing? Intake and output. We monitor IV fluids and we adjust, usually according to standing waters. We monitor the color, amount, and type of fluid in the drains. Hypothermia and malignant hypothermia, these were discussed in the intra-op lecture. So now we're going to talk about the different types of anesthesia. And is the patient management in the PACU different based on the anesthetic used? Absolutely. For general anesthesia, the things we watch are respiratory depression and level of consciousness. We need to turn the head to the side to drain secretions because the patient is not capable of doing it themselves, and we need to maintain the artificial airway or endotracheal tube. For regional, spinal, and epidural anesthesia, we need to position the patient flat if it's spinal anesthesia. We need to hydrate these patients. Why is hydration so important? Regional anesthesia can lower blood pressure. IV fluids are important because they help to prevent both spinal headache and neurogenic shock related to vasodilatation of the blood vessels. Local conduction blocks, an example would be a brachial plexus block which anesthetizes the arm. Therefore, we need to assess sensation return in the specified area. Also of note, with general and regional anesthesia, we need to watch for the vital signs. We also have to consider the two groups that are listed here, both the gerontological population and the bariatric population. So for the gerontological population, things that we have to consider are these clients have less subcutaneous fat, so they are at greater risk for hypothermia. Thermoregulation is imperative for these patients. These clients require frequent position change to stimulate respirations and promote circulation. They have prolonged time to clear sedatives and anesthetic agents. Electrolyte imbalances, hypoxia, and blood loss can present as confusion. We have to avoid contributing confusion to age. Other factors need to be ruled out first. and mobility may be painful or even difficult due to arthritis. For the bariatric population, special considerations include properly sized blood pressure cuffs, gowns, transfer devices, and wheelchairs. These patients are at increased risk for VTEs, DVTs, and pulmonary embolisms. They are also at increased risk for pulmonary complications and obstructive sleep apnea. Indicators of recovery from anesthesia and readiness for discharge from PACU, also known as the ticket out of the PACU, include a stable blood pressure, adequate respiratory function, and adequate oxygen saturation compared to baseline. More specifically, the client can deep breathe, cough, and the gag reflex is intact. Vital signs are stable, including blood pressure, heart rate, and respiratory rate, and oxygen saturation minimally of 90 to 92%. Nausea, vomiting, and pain are under control. The client is oriented ×3. They can move their extremities, and sensation has returned if regional anesthesia was administered. Some PACUs use a scoring tool to determine readiness to leave PACU, and we're going to discuss that in the next slide. So here's an example of a scoring tool used to determine patients' readiness for transfer out of the PACU. The Modified Aldrete score is a scoring system based on a set of objective criteria used to determine the patient's general condition and readiness for discharge from the PACU. The score is based on activity, respiration, circulation, consciousness, and oxygen saturation. And each area is scored a 0 to 2. If the total score is less than 7, the patient is not discharged from the PACU. Usually a score of 7 to 10 is required for discharge. And this tool was adopted from Aldrete, Wright, and from the Anesthesiology News. We also want to assess for nausea and vomiting. Generally, patients feel less nauseated. Most antiemetic meds are given IV push. Fluids in, fluids out. IV, we assess the site for patency and validate IV infusions are the correct solution and rate. Drains, we assess for not only the amount, but the type of drainage. The Foley, if there is one, we check the amount of urine output in the indwelling urinary catheter. And if there's no indwelling urinary catheter, we use a bladder scanner to determine distension, retention, and post-void residuals. For neurovascular assessment, careful attention if it's back, neck, or extremity circulation for this area. We review post-op orders for ordered IV fluids, pain meds, activity level allowed, and diet ordered. We want to review the PACU record, what anesthetic was used, and what was the estimated blood loss. We reinforce coughing, deep breathing, and incentive spirometry. And remember to keep both the patient and the family updated. In this slide, we see some incisional drains. These drains allow for the escape of fluids, both blood and serous, that can otherwise serve as a culture medium for bacterial growth and put pressure on the incision. Types of drains inserted in surgical wounds include the Penrose drain, which drain into the dressing, and you can see the dressing and that white bar is actually, Penrose drains are usually these thin rubber tubes that just drain right into the dressing. A Jackson Pratt, that looks like a grenade. In order to empty it, we open the spout, we empty it into a cup. I prefer to use a sterile cup in this instance. You squeeze out the air and the fluids, keep it closed or squeezed in your hand, and then put the spout back in. For a hemovac, which is the bottom left-hand drawing, you open the spout to empty it. Again, you empty it into a sterile cup, and then you press it down like an accordion and then close it shut. The Jackson Pratt and hemovacs are usually self-suction. However, sometimes they are attached to wall suction. And here are some common postoperative nursing diagnoses. Risk for diagnoses include ineffective airway clearance, and this can be related to a decreased respiratory function or pain or bed rest. Decreased cardiac output can be related to shock or hemorrhage. Ineffective thermoregulation can be related to surgical environment and the anesthetic agent used. Constipation is usually related to the effects of the medications, the surgery, the dietary changes, and immobility. Imbalanced nutrition, which is less than body requirements, can be related to decreased intake and increased nutritional needs related to the surgery. Urinary retention can be related to the anesthetic agent and immobility, and disturbed body image can be related to the surgery itself. Actual diagnoses include acute pain related to the surgical procedure, anxiety related to surgical procedure and management post-op, impaired skin integrity related to the surgical incision and drains, and activity intolerance related to generalized weakness secondary to surgery, prosthetic devices needed, and restrictions. Common problems post-op are pain and anxiety. So we're going to delve a little further into pain assessment. Many patients are unable to accurately report their pain level in the post-op setting due to sedatives and other medications given during surgery. Nurses must be able to accurately assess other factors such as behavior, vital signs, level of consciousness, and the pre-op baseline. Intense pain stimulates the stress response, which adversely affects both the cardiac and immune systems. Both muscle tension and local vasoconstriction occur, causing ischemia and further stimulation of pain receptors, increasing both myocardial and oxygen demand. The stress response also results in increased blood viscosity and platelet aggregation, increasing the risk of thrombosis and pulmonary embolism. We assess pain using a 0 to 10 scale, and the patient can speak. We assess anxiety. It will definitely increase the patient's pain. We assess their position. Poor position in bed will aggravate pain. And a realistic goal for post-op pain management is toleration rather than elimination of pain. We have several ways to manage postoperative pain. In the top left, opioid analgesics When given IV push, the RN must know the rate in minutes to actually administer it so that it is safely administered. And we need to watch blood pressure, respiratory rate, level of consciousness when administering IV push opioids. On the left bottom, you see a PCA pump. When the patient is on a PCA pump at specified times, the RN must chart the respiratory rate, blood pressure, level of consciousness, and in some hospitals they also require how many times the patient pushed the button in the last 4 hours. There are some other requirements. Only the patient is allowed to press the button, not the RN and not the family. Requirements are an understanding of the need to self-dose and the physical ability to do so in order for the patient to be on a PCA. Epidural, the top right, infuses via pump like a PCA into the epidural space, usually a mix of Novocaine drug and opioids. These are used with caution in chest procedures because the analgesic may ascend along the spinal cord and affect respirations. We also want to watch the blood pressure. The on-cue pump, which is the bottom right-hand drawing, subcutaneous pain management system consists of a pump, filter, and catheter that delivers a specific amount of prescribed local anesthetic at the rate determined by the physician. Once empty, the on-cue pump is removed. It's also interesting to note that research studies have demonstrated pre-op teaching can reduce post-op pain. The type of surgery, anesthesia, and incision location can also affect the degree of pain. And it's also interesting to note that orthopedic surgery and abdominal surgeries are very painful. Talk about postoperative complications. I'm going to start with urinary complications. Urinary retention occurs after surgery for many reasons, including anesthetics, anticholinergic agents, and opioids, which interfere with the perception of bladder fullness, the urge to void, and inhibit the ability to initiate voiding and completely empty the bladder. Assessing for bladder distension and ability to void post-op is very important. The patient should void in 8 hours if there is no Foley. If there is a Foley, we check the output hourly, and they should have at least 30 mLs per hour, which indicates effective kidney function. If the output is less than 30 mLs per hour, we want to consider causes such as blood loss, hemorrhage, and/or dehydration. If blood loss during surgery is significant, kidney function can be negatively affected. Note that the kidneys receive a large amount of cardiac output. If there is extensive blood loss in surgery or dehydration, urine output will be decreased. If the Foley remains in for greater than 48 hours and after removal, be alert for signs and symptoms of a urinary tract infection. They are burning, urgency, frequency, elevated white blood cells, red blood cells, and bacteria in the urine. The goal of nursing interventions is to prevent urinary complications. How do we do this? We promote voiding within 8 hours post-surgery. We utilize measures to promote voiding: a warm bedpan, sound of running tap water, warm water over the perineum, out of bed to the commode or toilet, and oral fluids if permitted. The patient may need to be straight catheterized once or even every 4 to 6 hours until bladder tone returns. Bladder ultrasound may be done to check post-void residuals, and we want the post-void residual to be less than 100 mLs of urine. We may get an order to give IV fluid bolus if they are not making sufficient urine, and they give about 250 mLs per hour for 2 hours for a total of 500 mLs. Assessing for postoperative GI complications. Nausea and vomiting are most common in the PACU due to the effects of anesthesia, but the patient may experience nausea on the clinical unit from the opioid meds. We may give metoclopramide, also known as Reglan, which is a GI stimulant for gastroparesis, and/or antiemetics, and we've talked about these already: prochlorperazine, promethazine, ondansetron are some examples. Constipation can occur from decreased mobility, decreased oral intake, and opioid medications. Patients should have a BM by day 2 to 3 postoperatively. A paralytic ileus is a cessation of bowel peristalsis. We assess bowel sounds, we look, listen, and feel. And when we do that, the head of the bed is no greater than 30 degrees for this assessment. Distension due to accumulation of gas, we also monitor for that. Patients are NPO before surgery, but air is swallowed and GI secretions enter the stomach and intestine. If the air and swallowed fluids are not propelled by peristalsis, they will collect and cause distension, possible nausea and vomiting. And there's some nursing research has found the absence of nausea and vomiting and distension are actually better indicators of resumed peristalsis versus the presence of bowel sounds. So again, the goals are to prevent GI complications or interventions. And they are early mobility, dangling the legs out of bed to the chair, and ambulation as soon as ordered. We increase dietary fruit, fiber, and fluids. Stool softeners, laxative mild ones often given prophylactic to prevent constipation. And affleets may be needed if the prophylactic measures, stool softeners, and mild laxatives are ineffective. The three major postoperative wound complications are bleeding and hemorrhage, dehiscence and evisceration, and infection. For bleeding and hemorrhage, we check the top and under the dressing. We look for bleeding with a tonsillectomy in particular, with all surgeries, but tonsillectomy is its own special, and we're going to talk about that towards the end of the lecture. We mark bloody spots. We talked about this before. We outline the bloody drainage with a pen or a marker, and we write the date and time. We want to check under the dressing for blood. We also check for hematoma, which is a clot beneath the surgical site due to concealed bleeding that stopped. And we have to remember that blood will flow via gravity, so you may not see it on the dressing, but actually underneath. And sometimes it even oozes. If it's an abdominal wound, it may ease out and be under the patient. Going back to the hematoma, if it's small, it's usually reabsorbed by the body. If the hematoma is large, the wound will bulge and there will be a delay in healing unless it is surgically evacuated. Next, we're going to talk about dehiscence and evisceration. And the picture on the bottom right shows you both. Dehiscence is the disruption of the surgical incision. Evisceration is the protrusion of wound contents, and this is a serious complication, especially with abdominal wounds. These complications can result from sutures giving way, marked abdominal distension, strenuous coughing, and/or infection. A slow evisceration, what you see is a gush of serosanguinous peritoneal fluid. With a sudden rupture, we see coils of intestine. Infection. Is the incision infected? And that may not be evident until even 5 days postoperatively. The symptoms are tachycardia, temperature elevation, elevated white blood cells, wound edema, warmth, tenderness, increased incisional pain, and/or discharge. In surgical patients, most common nosocomial infection site is actually the incision versus something like a Foley catheter or a central line. Wounds at risk for infection, there are 3 categories. The first one we call clean contaminated, and these are respiratory, genitourinary, and oropharyngeal tracts. An example would be an appendectomy. The second is contaminated, and these are new trauma wounds or gross spillage from the GI tract. And the last one is dirty, and these are traumatic wounds with delayed repair, fecal contamination, foreign bodies, purulent drainage during the procedure. Surgical wound healing occurs in 2 ways. First intention healing, the wound edges are closely approximated, there's no granulation tissue visible, and an example would be a sutured surgical wound. Second intention, granulation tissue is visible, the wound edges are not well approximated, and this can occur with a wound abscess. With wound abscesses, even if an incision and drainage is done, dead dying cells that form the walls of the abscess are still released into the cavity, so a drain must be put in and the wound cannot be resutured. So how do we prevent skin and wound complications? Nursing interventions include turning and positioning, which we know has multiple benefits to the patient. We want to keep the dressing intact, and that's unless it's like a liquid dressing such as Liquiband. These, when they're used, there is no cover dressing. We change the dressing as ordered. We work with the patient. We change at a suitable time. For example, we don't want to do it during mealtime. Remember to explain to the patient dressing change is a simple procedure associated with little discomfort. Provide privacy, hand hygiene, wear gloves. Most dressing changes following surgery are sterile. Make sure you have your supplies, that we remove tape or adhesive in the direction of hair growth. We dispose of old dressings in a biomedical waste bag. This is a great opportunity to educate the patient on how to care for the incision at home. Clean wound if designated, and you manage dehiscence and evisceration. And how do we do this? If the patient is eviscerating, we place them in a low Fowler's position. We have the patient lie quiet. We cover the intestines with sterile, moist saline gauze, and we call the physician immediately. Some factors that can impair wound healing. With the elderly, tissue is less resilient, so the age of the patient affects wound healing. Obesity, the subcutaneous tissue is not well perfused with capillaries. The more subcutaneous tissue, the less circulation, leading to slower healing. Poor nutrition, low serum albumin affects tissue repair. Recent steroid therapy will affect inflammatory response, which is a part of wound healing. It may mask the presence of infection, and some drugs that are examples of steroids are prednisone and methylprednisone. Compromised immune systems. Patients that have compromised immune systems are more vulnerable to wound infections. Hemorrhage, infection, and wound edema. Blood is a medium for multi-organism growth. They can be infected drainage, and edema puts pressure on the wound wall. Overactivity, vomiting, valsalva, vigorous coughing produce tension on wounds, particularly of the torso, and can lead to wound dehiscence. So what nursing interventions promote wound healing? We protect the wound, a dressing, rest, splint to cough if it's an abdominal wound, a regular diet as soon as possible, assess serum albumin and glucose levels, and ambulation will increase circulation to the wound site. The stress response that is initiated by surgery inhibits the thrombolytic fibrinolytic system, resulting in blood hypercoagulopathy. Dehydration, low cardiac output, blood pooling in the extremities, and bed rest add to the risk of thrombosis formation. Deep venous thrombosis, or DVT, the signs and symptoms include edema, feeling of heaviness, differences in leg circumference from the thigh to the ankle, and increased surface temperature of the affected lower extremity. It is important to note that tenderness in the affected lower extremity is a later sign. Pain in the calf when the foot is sharply dorsiflex was previously used to check for DVT. It is not specific for DVTs. Instead, we use ultrasounds or lower extremity Dopplers. They are more precise to diagnose a DVT. And fluids. If the patient is dehydrated, there is a greater chance of DVT as blood cells are floating in less fluid. Pulmonary embolism. Signs and symptoms include tachypnea, chest pain, hemoptysis, shortness of breath, and feeling of impending doom. Sometimes it even presents as anxiety. And this is an absolute emergency. Nursing interventions to prevent circulatory complications include early ambulation, external pneumatic compression and anti-embolism stockings, leg exercises, and we want to avoid any form of elevation that can constrict vessels under the knees, hydration, and pharmacological prophylaxis, such as subcutaneous and/or oral anticoagulants. Some examples are heparin. It's given sub-Q, it's inexpensive, and it needs to be given 3 times a day. Low molecular weight heparins are also given sub-Q, and examples would be enoxaparin and dalteparin. Oral meds include warfarin, dabigatran, fondaparinux, rivaroxaban, apixaban, and edoxaban. Respiratory complications include pulmonary congestion, which occurs when secretions are not cleared from the airways. It is more common in elderly patients whose weaker cardiovascular systems allow stagnation of secretions at the lung bases. Symptoms are often vague, with possible slight elevation in temperature, pulse, and respiratory rate, as well as a cough. Assessment reveals dullness and crackles at the lung bases. Pneumonia is an infection. Signs and symptoms are chills, fever, tachycardia, and tachypnea. Cough may or may not be present and may or may not be productive. Atelectasis, which is alveolar collapse. It's an incomplete expansion of the lungs. When a mucus plug obstructs one of the bronchi entirely, the pulmonary tissue beyond the plug collapses, resulting in atelectasis. Signs and symptoms include decreased breath sounds over the affected area, crackles, and cough. And we need to know when to report oxygen saturations. We always report anything less than 90%. Some post-op protocols may require higher numbers, such as less than 92% or even as high as less than 95%. So how do we prevent respiratory complications? First, incentive spirometer. Opioids and bed rest decrease lung expansion. We want to make sure the patient uses the incentive spirometer minimally every 2 hours and optimally 10 times per hour. Coughing and deep breathing every 2 hours. If abdominal surgery, be sure to splint the abdomen with a pillow, blanket, or have the patient even interlace their fingers to form their own splint. Oxygen and suctioning. O2 may be needed for the first 24 hours. O2 via nasal cannula at 2 to 3 liters per minute is always given when the patient is on a PCA. Suctioning is actually more commonly needed in the PACU, unless the patient has a new tracheostomy, and this is a skill you'll learn in Nursing 2 lab. Early ambulation is crucial, and we want to maintain the blood volume. And how do we do this? We maintain the IV rate, and we encourage PO fluids. It's really important that you individualize your postoperative interventions. So, for example, are all patients allowed out of bed at the same time? Well, the answer to that is no. But more and more MDs want the post-op patients out of bed the day of surgery or post-op day number 1. Are all patients transferred out of bed the same way? And the answer to that is also no. If the patient had spine surgery, we have to transfer them in a special way. All patients dangle first, and we must be cognizant of orthostatic hypotension and the risk for falls with that. So side effects of narcotics include decreased blood pressure and respiratory rate, itching, and constipation. And do all patients get these side effects? No. Are IV infusions all discontinued on the same post-op day, and who decides? Well, most RN units have standing orders, and these orders are pre-written and allows the nurse to make decisions based on these orders. So, for example, once the patient is taking sufficient PO, DC the IV fluids would be an example of an order like that. Do all patients have dressings on their surgical wounds? Well, we did talk about like a Liquiband dressing, so no, they do not. Some have clear spray type dressings, and some are even open to air with staples. A tonsillectomy is indicated for patients with chronic tonsillitis despite antibiotic therapy, tonsil hypertrophy that can cause obstruction and obstructive sleep apnea, repeat purulent otitis media, and hearing loss due to serious otitis media. Position in the immediate post-op period, the prone position is most comfortable for these patients. Turning the head to the side allows for drainage of mucus and blood. Hemorrhage is a serious risk that can obstruct the patient's airway with tonsillectomies. For discharge, we want to educate the patient and the caregiver about signs of hemorrhage. Let them know that they'll be taking liquid acetaminophen with or without codeine for pain relief, and the pain will subside in 3 to 5 days. To complete the full dose of antibiotic therapy, they can use alkaline mouthwashes. Soft foods are more easily swallowed, and they want to maintain good hydration. This is an acronym you can use to teach the patients to help prevent postoperative complications, ICOF. The I stands for incentive spirometry, C for coughing and deep breathing, O for oral care, U for understanding their instructions, G for getting out of bed frequently, and H for head of bed elevation.